I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and I'm just back again from the American College of Gastroenterology annual meeting in Philadelphia. This is part 2 of my highlights. These are not done in any particular order, but just I called out of the thousands of abstracts and presentations what I thought would be most exciting from my perspective. Let's share part 2. If you haven't seen part 1, I'll link this for you as well in today's discussion. Let's get right to it. Well, the first was about video capsule endoscopy, and we've heard a lot about the GLP-1 agonists, the glucagon-like peptide 1 receptor agonists, talking about endoscopic risks and retention and aspiration risks. Well, this was looking now from the group at Mayo at Jacksonville about capsule endoscopy and the impact of the GLP-1 use compared with patients that did not have that, but were still being treated with diabetes. This is not in the obesity category, but retrospective matched cohort study, and they well balanced again between the two groups. And what they found was that 7% of the 68 patients in the active group, the GLP-1 group, were actually failed to pass through the stomach, while the controls passed. And the GLP-1 group had a longer transit time. It wasn't statistically different, but it was increased by a factor of almost 4 times. And the multivariate analysis also showed that the time was approximately 80 minutes longer in this particular group of active GLP-1s. And interestingly, 16 of the 68 patients failed to pass, and that was 24%, failed to pass the small intestine. And again, this is highly different than the control group, which was 4%. So again, need to look at potential strategies to mitigate these effects, but certainly be aware of these as you start to do capsule endoscopy in the GLP-1 patients. Second was, that caught my eye, was the incidence of young Barrett's as increasing as their population study. Again, a multi-institutional national database. In this, they looked at the TRINEX database, which is a composite health record of 88 organizations, and they looked at the incidence of Barrett's. So you had to have a negative biopsy, a negative endoscopy for Barrett's, and then subsequently the development of Barrett's over the course of different stratified ages. And they looked at young, less than 50, and they looked at intermediaries from beyond that in different age groups. But the young Barrett's accounted for about 20% of the incident cases. The majority had non-dysplastic Barrett's, and the incidence was not that much different as it relates to the 45 to 49, and then over 50 to 54. But there was a significantly increasing trend in the young Barrett's as it relates particularly to specific, by regression analysis, risk factors: hiatal hernia, odds ratio is 2.6, smoking 2.3, white race, odds ratio 2.3, obstructive sleep apnea 2.2, male gender 2.0, GERD symptoms relatively lower, 1.2, and the same for BMI. They didn't again categorize based on tropho-obesity, which is one of the factors that we've seen for the cohorts as it looks to national recommendations. But again, we start to look at the increasing incidence of Barrett's esophagus in younger patients. And in particular, 6% of the younger patients had Barrett's-related neoplasia. So recognized guidelines say begin at 50, and with the fact of other cofactors and that listed in the odds ratios here. But again, this may not capture some of the increasing incidence. We've seen the age shift as it relates to colorectal cancer. Maybe we should reevaluate this as it relates to Barrett's and specifically some of these risk factors. The caveat, beware, and I'll give you a personal experience that I was biopsied for Barrett's, short segment Barrett's. It came up on my health record, and it increased my insurance premiums, which we looked at, and it created me now as a healthy person, but as a healthy smoker. Nick Shaheen did a study a number of years ago, and actually many groups would not even certify these young, healthy people otherwise as insurable. So be careful and be aware of this when you start to look for Barrett's, especially in the younger patients, but the incidence seems to be increasing. Next was a cendakimab, which is a biologic agent as it relates to EoE, eosinophilic esophagitis, and this is a randomized placebo-controlled phase 3 study. And recognize that we have dipepimab, which is a anti-IL-4 antibody. This is now an anti-IL-13 that neutralizes IL-13. It's a cytokine playing a key role, as you recognize, in EoE. So this was presented by Dr. Evan Dillon from UNC. They looked at this in a basically a controlled trial. They were looking at different dosing. The first dose was the active drug, 360 milligrams once weekly for 48 weeks. The second arm was 24 weeks of the same drug, and at 24 weeks you were then switched to every other week or placebo. There was a significant effect for the both active drugs. There was really not a whole lot of difference between those that switched over to every other week at 24 weeks. There was minimal as it relates to significant adverse events to separate, and certainly as it relates to discontinuation, not really significant. So I do think that we'll see this drug more available as it goes through the FDA process, but adding to our ability to use formative biologics in EoE patients. Next one was a very interesting study, and I think clinically relevant, a fecal transplant as it relates to alone or bezlotuximab, which is recognizably a fully human monoclonal antibody that binds to C. diff toxin B. This has been studied, approved for use, but it's extremely expensive. The dose of that is approximately $4,100 from what I could see. But here they were looking at it specifically in patients with C. diff recurrence in IBD patients, so they had to have at least 2 episodes of C. diff. In IBD, they were then, again, randomized 1-to-1 to receive a single dose of the bezlotuximab infusion prior to the FMT, and then the endpoints for primary outcome within 8 weeks with C. diff diarrhea plus a toxin positive. Secondary outcomes was C. diff colonization or decolonization after the treatment. Again, this was not statistically different between either course, so the bezlotuximab didn't seem to add much and wasn't necessarily imposing as it relates. The risk factors for ongoing colonization seem to be increased in patients that had steroid use going into the FMT. So it doesn't seem to add here. More is better, equal and non. It doesn't seem to justify the combined use. Next was a really reassuring study on ciladeparin, which is something that just released in August of this year, and you may have seen the New England Journal paper as it relates to biliary cholangitis back in February. But this is a peroxisome proliferative activated receptor delta agonist that works in particular in biliary cholangitis by blocking bile acid synthesis, by regulating the genes involved in biliary bile acid synthesis and controlling inflammation and fibrosis. So that rather than the index report, which is a phase 3 study, that removed decompensated patients. This was actually looking at a subset of the patients in that controlled trial that had compensated cirrhosis. So these are patients that predominantly had child's A and B, and it accounted for about 94% of the patients involved in the study. And the good news was that taking ciladeparin 10 milligrams orally daily, and these are patients that had been intolerant or non-responders to ursodeoxycholic acid previously, and this is again follow-up now at a year. There were no safety signals. Again, I think this is reassuring even for the patients that had compensated cirrhosis. Another one that really key, and you have to pay attention to this, is the vaccination recommendation as relates to IBD patients. Respiratory syncytial virus vaccination is available, and if you look at the recommendations for IBD patients and go back as late as the Canadian GI Society publishing Gastro back in 2021. I'll give you those links as relates to live and the attenuated or the non-live vaccines. We are very aggressive, or should be, in our IBD patients, but we haven't really had RSV vaccine on our radar. And this is a retrospective cohort study looking again at the TRINEX database, over 100 million unique patient charts. And they looked at the patients that had IBD, and they divided them into 2 groups, patients that received the vaccine and those that didn't. And they looked at age of 60 as a discriminant. Recognize the CDC recommends that this is a dose for all over 75 and limits it for 60 to 74-year-olds based on severity of risk. But here the endpoint was looking at patients that had an incidence of RSV pneumonia. The odds ratios were dramatically better, 80% risk reduction. Acute respiratory failure risk reduction was over 60%, and hospital patient admission for this odds ratios reduced by about 50%, and ICU odds ratio as relates to a significant infection with ICU services, odds ratios reduced to about 70%. So this is a really strong study to show that RSV vaccine, number one, didn't exacerbate IBD, but it improves the outcomes in these patients. Recognize there's an attenuated vaccination, which again is live. That's a transnasal administration that wouldn't be used in your biologic or immunosuppressed patients with IBD, but the other is the vaccine, which is intramuscular, and that certainly doesn't have any risk as a live vaccine, even an attenuated vaccine. I think this seems to be on our immediate due for our patients with IBD, particularly in those 60 or greater. Next was one that I think is also very important, looking at the impact of palliative care consultation on 30 and 90-day readmission on patients with decompensated cirrhosis. And again, recognize that this is a major cause of morbidity and mortality, and the National Readmission Database was queried for this particular study over a 10-year period, 2010 to 19, and they looked at readmission rates based on if they received a palliative care consult. Now, there were over 1.6 million admitted with decompensated cirrhosis, so a huge number of these. Only 7.4% received a palliative care at the index admission. But if they had that, the dramatic effect was that they had a major effect on readmission at 30 and 90 days. This is dramatic and highly statistically significant. Odds ratios were approximately 70% less likely to have a 30-day or a 90-day readmission compared to if you didn't receive the palliative consult. Take-home message here: get a palliative care consult on these patients when they come in. It has tremendous value. Your hospital will unquestionably have value in this, and readmission, and certainly within 30 days may not even be covered. So again, look at this and start to use this valuable consultation. The last one I wanted to highlight was really interesting too, as it relates to a drug called Orexia. You may or may not have heard about this, but this is a drug that changes calcium channel, and it relates to, it's a calcium channel inhibitor. Orexia, there is growing data about calcium release activated calcium through this channel, that it aggravates acute pancreatitis, in particular accelerates systemic inflammatory response, or SIRS. So recognize that acute pancreatitis with necrosis is something that is a local and systemic inflammation, and it has significant mortality. The morbidity of this in the necrosis, it's the population coming in, 20 to 30% have pancreatic necrosis, 30% develop infection, 25% develop organ failure. The presence of SIRS seems to herald the activation of this complex inflammatory pathways, which then leads to this organ failure and cirrhosis, and necrosis. But it does, again, stem through this calcium channel inhibitor, the drug Orexia, that phase 2 studies 2 years ago actually demonstrated that there was significant risk reduction as far as progression. So this is now phase 3 study looking at international acute pancreatitis. They had 2 or more grade criteria for SIRS, and they were randomized to receive dose ranging of the active drug as it relates to 2 milligrams, 1 milligram per kilogram, or 0.5 milligrams versus placebo. This was given over 4 hours for 3 consecutive days. The primary endpoint was time to solid food tolerance, defined as eating at least 50% or more of a 500 calorie or greater low-fat solid meal without increased abdominal pain or emesis. This is something we try and do in acute pancreatitis, get them to have enteral nutrition. A key secondary endpoint was severe respiratory failure, defined as mechanical ventilation, or at least 48 hours of either high-flow nasal cannula or non-invasive mechanical ventilation. All these parameters were measured. The primary endpoint was dramatically improved, in particular as it relates to the drug intervention. No patient really had any adverse event-related unexperienced adverse reactions to this, but a dramatic improvement as relates to early onset of refeed, and none went on to develop respiratory failure in the active drug administration for across all the doses. It appears that the high doses of the 2 milligrams per kilogram may be the one that seems to be most beneficial, but present time, I can say that this drug, new Orexia, decreases the time for solid food tolerance, as well as the rates of respiratory failure and necrotizing pancreatitis in patients presenting with at least 2 or more SIRS criteria. We'll certainly look forward to more data on this, but it really provides a very hopeful new treatment as it relates to acute pancreatitis. So to data, we'll obviously like to see these manuscripts evolve. some of the messages I left for you today are actionable now, and some we'll wait and see where the data shows and what the process for approval and use in the present day. Dr. David Johnson, thanks again for listening.